hear your voice and to see the team. And it's my absolute pleasure to be here. That was a very kind introduction. So yeah, I mean, I guess I'll confess right off the top that it was a bit of a running joke during my fellowship about my love for magnesium, how it rained magnesium everywhere I went. And so it's been a point of much ribbing, but I hope to at least vindicate some of the reasons why that might be worth paying clinician consideration. I didn't look for magnesium. Magnesium sort of found me when I was a first-year medical student. I was pregnant with my first child, and I had the most horrific, painful nocturnal leg cramps. I was up every night, and my obstetrician very casually suggested that I try taking some magnesium, so I did. And that really promptly resolved my symptoms, so much so that the nights that I still woke up with cramps, I would think and reflect, had I forgotten to take it? And, you know, that was exactly what had happened. If I had forgotten to take it, I would still suffer with these cramps. So that's sort of how I kind of was introduced to it. But then throughout medical training, I also kept coming across these really interesting cases. In clerkship, I had a case of atrial fibrillation that was very symptomatic, was not reverting to normal sinus rhythm, despite cardioversion and amiodarone and all the usual you know, really invasive things. I mean, it's not a fun drug, and still not reverting to a normal sinus rhythm. And we came in after 1 weekend, my supervisor and I, and the physician over the weekend had magically somehow corrected this really problematic AFib patient. So when we asked what he did, he said, well, I checked the magnesium level and it was really low. So I corrected it, and not everything else you guys did suddenly started to work. So that's where I first learned about its use in cardiology. It's a calcium channel blocker, a vasodilator, all these things. And then as I progressed, I came across a psychiatrist who regularly added it as an adjunct for depression management, along with omega-3s. There was a family doc who had prescribed it and found that when he added it, his patients' diabetes, A1Cs improved, and in one case, quite dramatically so, over 1% A1C, which is what we would expect from your typical anti-hyperglycemic. So all these cases kept coming forward. And anyway, you guys are all going to say, well, so we don't care about that. We're paying clinicians, so, you know, let's talk about that. But all of this is sort of intertwined. So hopefully I can bring you to sort of an interest in it the way I was. Just in terms of disclosure, I have no conflicts of interest to declare, aside from the fact that I'm unreasonably excited about magnesium. Our objectives today are to look at some of the physiological effects of magnesium on the body, to understand the pharmacokinetics of various magnesium formulations, to recognize the limitations of research done on magnesium, and then potentially applying it to different chronic pain scenarios. So, I mean, we're all nerds here. If you're at a party and you run out of things to talk about, I mean, this is really interesting stuff. It's the fourth most common element in the body. Half of it is distributed in the bones. Half of it is stored in muscles and other soft tissues, and only less than 1% of it is distributed in the serum. It's the second most abundant intracellular divalent cation after, you guessed it, calcium. And it's this is actually an older paper. A newer paper I came across said over 600 metabolic reactions involve magnesium in the body. And this ranges from bone metabolism and nerve transmission, cardiac excitability, neuromuscular conduction, muscular contraction, vasomotor tone, blood pressure, metabolism. It's quite integral to mitochondrial function and the maintenance of ionic gradients across the sarcolemma, and maintaining a normal resting membrane potential of the excitable cells in our body. The total body store ranges from 21 to 28 grams. And if you've lost the people at the party by this point, you can also bring out, hey, it actually makes really cool explosions, and you might find the life return to your party. So in terms of the physiology, this is a graphic that on a very basic level shows some of the roles of magnesium in the body. It is integral to DNA replication and repair, in bone formation. It's involved in the NMDA receptor function, calcium channels, and it's a cofactor for many molecules. And one of the important ones we're going to talk about is magnesium when it's combined with ATP, which is the energy molecule in our bodies. So if we look at specifically the N-methyl deaspartate receptor, this is a receptor that's thought to be involved in chronic pain in terms of sensitization syndromes. So, you know, the pain that ends up becoming chronic, it all starts by priming of pain signals with the function of this receptor. It's important to know that magnesium is technically not an antagonist of the cell. It's part of the resting state of this receptor. So when the magnesium plug is in place, it's how the cell maintains a resting state. When it's missing or when we're low on magnesium, then this receptor becomes more excitable. It is more apt to be active. The actual antagonists of this receptor are PCP, and then of course we all are familiar with ketamine. And so it doesn't necessarily bump out magnesium. These can work together at the same time. They're not mutually exclusive. So just some fun facts there. Then in terms of musculoskeletal function, this is a zoomed in version of a muscle fiber, basically, where you have the myosin, which is the flexy part, and the actin rods, which is the stiff part of the muscle cells. And basically, when the myosin head detaches from the actin filament in relaxation, it requires a molecule of ATP, and ATP gets shuttled around in the cell, not in its ionic form, but, you know, combined with a molecule of magnesium. Magnesium is the cofactor in that energy molecule. So in essence, when we're low on magnesium, this relaxation is slower to occur because the molecule needs to be in a balanced state to that site to release. So you can see this may have a very real impact on overall muscle tension. Now here, I get that this might make your eyes a little bit challenged. I'm talking about electrophysiology here. So if this is too much for you, just focus on the fainting goat. But on the left here, basically, you're seeing action potentials. So that's a stimulus running through an excitable type of cell, such as a neuron or heart muscle or muscle tissue. And in the absence of magnesium, the cell or the resting membrane is more excitable. But then as you go along with increasing concentrations of magnesium, we can see that the action potentials slow. And then on the far right, you start seeing where toxicity comes into play when there's too much magnesium and the resting membrane threshold is higher. And this is where you will see the difficulty in initiation of action potentials that may lead to symptoms of muscle weakness or the loss of patellar reflexes, or even respiratory depression when we're using high amounts of magnesium, for example, like they might use in a critical care setting. So that's something you know, to kind of understand the balance between low and high levels of magnesium. So what are the pitfalls in understanding the issues around magnesium? So number one is, how do we measure it? And number two is pharmacokinetics and the bioavailability of it. And then looking at what are the issues in the research that's been done on it. So measurement caveats essentially boil down to the fact that there is no real simple and rapid, accurate laboratory method that gives you an overall sense of the total stores. So, and serum levels are less than 1% of the total magnesium in the entire body. So actually it's about around 0.3%. So it's really not useful in giving you a sense of how much resides in the tissue. It's most useful perhaps in a critical care setting if you're monitoring for toxicity, or if you're looking to establish a baseline. But even if it's normal, it doesn't mean their tissue stores aren't normal. But if you do see that the serum level is low, then that does give you a sense at least that they're profoundly low, because their tissue stores have to be depleted and their bone stores have to be depleted. And bone stores are more difficult for magnesium to come out of. So, when you get to that stage, you've really, either wasted or not absorbed magnesium to a sufficient level. So the actual best way of measuring it in a research study is MR spectroscopy, which is very not useful in the clinical setting at all. Then in terms of bioavailability and the pharmacokinetics, when you look, this is a very busy table, so I'm going to focus on the circled elements here. When we look at the magnesium salts that we commonly use, the first generation magnesium salts consist of magnesium oxide and magnesium hydroxide. And to kind of, nobody would mistake me for a chemist, so I apologize if Dr. Udon is on and he groans at my explanations, but magnesium is a 2+ cation and oxygen is a 2- anion. And when those two combine together, they form a double bond. And as we may remember from our high school chemistry, double bonds are much more difficult to break apart. So that means essentially when they get into your GI tract, it is essentially insoluble. Only about 4% of magnesium oxide is bioavailable that can get absorbed, and it really acts best as a laxative. Hydroxide, that's an OH negative molecule, also really low in terms of solubility, but when it does break apart, that OH molecule can sop up some of the hydrogen cations, so that's how it has a reasonably good effect as an antacid, but again, a very poor supplement because we're not able to absorb it. Now, people will often cite that magnesium oxide is good because it has high levels of elemental magnesium, but it's not great if you can't absorb it or break it down. So all that means is it's got a lot of magnesium molecules in a dose, but we still can't break them down. Second generation magnesium salts include magnesium citrate or gluconate, and those are better. You're getting better bioavailability and less side effects in terms of the GI stuff, but still people do have laxative side effects or diarrhea symptoms. When you get to the third generation magnesium salts, so that my favorite, as the team already knows, is magnesium glycinate. Not only do you have a really good higher level of elemental magnesium, but it's highly bioavailable, it's well absorbed, and it has the least amount of intestinal side effects. So that tends to be my go-to for those reasons, and we'll come back around to that a little bit later. Now, in terms of the body of research that is done on magnesium, like there's some evidence that shows that magnesium is good, and then there's some evidence that shows it doesn't work, and then there's just really terrible evidence. And ultimately, to sum it up for you, the evidence, generally speaking, is not really supportive of magnesium as a fabulous treatment option for multiple issues. And this even comes from what we would usually consider as reputable sources, such as Cochrane, and even a randomized controlled trial I came across from JAMA. But when you get into the nitty-gritty of the systematic review or the RCT, when you look at the quality of the study, like when you're looking at the lengths, at best you often see maybe 8 weeks. Only the migraine studies have done longer trials, and you're seeing systematic reviews where they lump together every formulation of magnesium, whether it's bioavailable or not, with significant differences in dosing. And the most common formulation used in the vast majority of studies is magnesium oxide. The studies also tend to be small, so there's not a lot of money in this. And when you try and make a systematic review on something that's based on, excuse me for saying so, but a pile of crappy studies, you're not really getting a good sense of whether or not it actually can do anything. So that's kind of a brief summary on that. And when I think about patients and what I'm looking for in assessments, what are the types of people that might be prone to low levels of magnesium? So, you know, very common things being common, patients who are being treated with diuretics for blood pressure, like hydrochlorothiazide, for example. PPIs, everybody and their dog is on a PPI, and often long-standing, and that really impairs absorption. Diabetics, they've done lots of studies that even in those diabetics who have normal serum levels, intracellularly, they tend to be very profoundly low. Kidney disease patients or dialysis patients, there's a lot of wasting that goes on. They're not able to retain it. Gittleman syndrome is a very rare syndrome. It only affects, like, I think 10 people in North America. Ironically, we have one of them in Thunder Bay, and she literally gets magnesium infusions every day of the week, 365 days a year. So it's not very common. Alcoholism, again, there's a lot of wasting that happens there. So anybody who's been drinking for a period of time is potentially prone to this. And you can see that like in the high levels of cramps that these patients get, and sometimes other issues. Pregnancy, it's very common as well, that baby's just sucking us dry for all the things that, you know, it needs to grow. And then anybody who's had post-bariatric surgery and has some kind of absorption issue as a result of that. But it could also be even things like inflammatory bowel disease or celiac, where there's ongoing inflammation and impaired absorption of nutrition. So those are kind of the things that I look for when I start to wonder whether or not this might be something that is an underlying contributor. So what we're going to do now is we're going to go through system wise and look at all the different ways that magnesium can contribute to function of a system, and then also pathology in very brief notes. So in terms of neurology, there's some interesting studies. They've looked at, you know, magnesium as showing positive reduction in stroke risk. They found that low magnesium is a risk factor for seizures. Again, coming back to that excitability issue with the resting membranes. Then there's some chronic diseases like Alzheimer's, Parkinson's, ADHD, where they've looked at relationships between low serum and CSF levels of magnesium in these conditions. Whether or not there's a causal relationship, it's not clear. They have tried magnesium, and it's may reduce the risk of cognitive decline in Alzheimer's. So moving on to endocrinology, particularly with diabetics, they're losing lots of magnesium, but it also really impairs insulin function and increases insulin resistance. And in terms of metabolic syndrome, there have been studies where they've found that taking supplementation resulted in a lower risk of developing metabolic syndrome. So cardiology is a big one, and that comes back to the excitability relationship magnesium has. Low rates of magnesium or low levels of magnesium can increase the heart rate and prolong the QT interval. And in hypertension, it can actually act as a mild calcium channel blocker. And some studies have even set up 10 millimeters of mercury systolic blood pressure reduction, which, by the way, is what we would look for an antihypertensive that we actually prescribe that may often have more side effects. It's been shown to reduce mortality and reduce infarct size in myocardial infarction. It reduces lipids, reduces pro-inflammatory markers that may increase the risk for clotting. And in terms of arrhythmias, it's used as part of the treatment algorithm for torsades. And they've looked at different levels of magnesium in terms of treating rapid AFib, up to 10-gram infusion at one time. And post-operatively, patients that get magnesium only had 2% resulting with paroxysmal atrial fibrillation compared to 21%. So it does seem to have a significant effect on heart rhythms. Respirology, it's sometimes used in severe asthma treatment as a bronchodilator, and can improve pulmonary function and reduce admissions when inhaled. Gastroenterology, so this is more particular to the magnesium hydroxide. It can be effective in treating dyspepsia. And it's not been studied in constipation. However, having said that, I mean, the laxative effect is the expected side effect. So I don't know that it needs a study for that. In terms of magnesium and gynecology or obstetrics, it is a standard of care in managing preeclampsia and eclamptic patients, and it has been shown to be superior to phenytoin and nimodipine in those patients. There's no harmful effects to the fetus or the mom. And I mean, take it with a grain of salt, the Cochrane reviews, but they looked at magnesium citrate and it was effective for leg cramps, at least in pregnant women. Can be useful in dysmenorrhea, where we find that it's more effective than placebo, and the patients were also shown to use less additional medications. In musculoskeletal issues, it's been shown to help maintain or improve bone mineral density, and the evidence for nocturnal leg cramps swings both ways. Having said that, I mean, I often look for nocturnal leg cramps in patients when I ask them about their sleep as part of my sleep history. And that to me is just another sort of potential clue if they may be low in magnesium, because there is a diurnal variation in magnesium in the serum. So apparently it's released into the bloodstream at nighttime, which may mean that intracellularly the tissues are a little bit lower, which has been hypothesized to be the reason patients get more cramps at nighttime. I've used it occasionally with great success in other patients. It doesn't seem to work, and I'm not sure why, but anyway, I think it's worth a try because it is a, you know, substantial or causes interference with sleep. For our mental health folks, it's got its fingers in all sorts of different pathways, you know, involved with regulating the release of GABA, glutamate, increase in serotonin, affects glutamate activity at NMDA receptors, thought to block the cytokine inflammatory cascade. So if you're looking, you know, when they postulate how it might work in depression management, so they have found that there is low levels of magnesium in CSF in depressed patients, but in terms of actually treating with magnesium, and again, who knows if we use a better formulation, if that would be different, randomized controlled trial have shown significant improvement compared to placebo in one trial. Another showed non-inferiority to imipramine, and another showed no difference with placebo. So focusing in on chronic pain specifically, this was an interesting systematic review that was published last year, and there's some big names that are interested in this topic. Like this guy, Dr. Rent Nielsen, was the former president of the IASP, and Dr. Gilleron is a pain doc out of the Kingston area, I believe, and has done lots of publishing. So they essentially, the long and short of it is they found that more research needs to be done, surprise, surprise, using more bioavailable formulations of magnesium to determine true benefit. So they didn't necessarily include some of the studies that I found. So I'm going to go through some of the different topics that have been studied somewhat. Migraines is probably the one with the most evidence for the use of magnesium. Now, ironically, they also usually have the longest trials, typically around 3 months. They have found a correlation between cluster and migraine headaches and low magnesium levels. They've done double-blind randomized controlled trials showing a daily dose of magnesium citrate to be effective in decreasing migraines compared to placebo. But it's also been shown in acute migraine to be statistically significant in managing symptoms of migraine. The only caveat to that is for people who might work in the emergency department, it does sort of work antagonistically to metoclopramide. So if you're going to use both, then just keep in mind that it may be negating the effect of another treatment you may use. And to be honest, in migraines, I have had patients where literally the only thing that I did was because they didn't either want medication, like actual first line prophylaxis, they wanted to try the supplements first. I have put them on magnesium and have had significant reduction in migraines in several patients by using magnesium, both in severity and frequency. And the Canadian Headache Society routinely, if you look at their guidelines, suggests prophylaxis with magnesium as the one supplement with the most evidence, followed by vitamin B2, followed by coenzyme Q10. And coenzyme Q10 is actually something that aids magnesium to get into the cell. So it may be related to that, in fact, not anything else. In fibromyalgia patients, there's not a lot of research, but there was an interesting randomized controlled trial that had 3 arms. One was magnesium only, another was a TCA, and the third was TCA plus magnesium. The magnesium only group did have significant reduction in tender points, but the best performing group did use a TCA plus magnesium. And so that's sort of kind of the approach I've taken, especially when they are complaining of something that sounds like myofascial or myalgic type of pain. I feel like it's reasonable to use both if the patient tolerates it. So, and I have seen some mild to modest benefit when patients use that. There was also a pilot study in fibromyalgia patients looking at transdermal magnesium that seemed to show benefits. And there are a few others, a handful that have shown benefit, but none of those were blinded, and most of those didn't have magnesium as a single therapy intervention. So I don't really draw any meaningful conclusions from those. Myofascial pain. So I think this is an area where we maybe stand to gain some of the most benefit. There's a really interesting pediatric case study that was published by CHIO, which is the Children's Hospital of Eastern Ontario, where they had this young 10-year-old who had presented to their pain clinic with severe pain, predominantly low back, that was resistant to all sorts of other treatments. And the long story short is they put him on magnesium because the parents didn't really want to try some of the quote unquote more difficult drugs. And the patient suddenly started to really improve drastically. So they gave him a magnesium loading protocol, and he essentially returned to a normal, healthy young child. There was an interesting study published on low back pain where they did IV magnesium followed by 6 months of oral magnesium, which I consider to be a reasonable duration of therapy to restore tissue stores. And they found that there were clinically significant lower pain scores when compared to placebo. I've had a couple patients where either they don't want medications or they don't want injections. And like I had one guy just last week who didn't have coverage. I actually ended up prescribing him magnesium oxide to my chagrin. And literally 6 weeks later, I saw him and he said, "That was a miracle. I haven't had a single muscle cramp or spasm since you put me on that." So, I mean, that's not the norm, but you get some of these home runs with something so simple, and it's really nice to see. The other really exciting home run I had was a patient that I inherited that was getting trigger point injections to like a dozen locations every 6 weeks. And he was a young guy. I was thinking to myself, what's the end game here? Am I really going to give this guy trigger point injections to a dozen spots for the rest of his life? So when I first consulted with him, I said, it seems mostly myofascial. You're otherwise a young, healthy person, but just humor me. Let's do some magnesium, do some foam rolling, and we'll check in. And if you're still having pain, I'm happy to book you. And this is a kind of an unsavory character. I really also truthfully didn't want to do trigger point injections on this guy for the rest of his life. And he came back and I was so relieved because he said, "You know what? That worked really well. I don't think I need trigger point injections. There's one that I still feel, but I'm using that trigger point one that you showed me, and I think it's okay." And I was just like, doing like a little internal dance. I was like, oh my goodness, it was, such a long shot. Then I was just trying to delay what I thought was going to be the inevitable because he'd already been set up to feel like he needed these injections. So that was that for me was a real personal win. With neuropathic pain, so the studies that have looked at this, there's not really been any clinically significant benefits. So it's not really part of the algorithm or one of the go-tos that I use in this. Having said that, there has been temporary benefit found during one study that was looking at post-herpetic neuralgia, but it only lasted for the duration of the infusion. So, I mean, you know, whether there would be a role for doing sort of a loading protocol or something to prolong that, I don't know, but I don't think it's overwhelming in support of. There have been some studies in CRPS in particular. There was one very promising pilot study that showed improved pain scores and quality of life. They used a pretty whopping dose though, so it was 70 milligrams per kilogram. So probably in the average sized adult, that would have been at least 5 grams infused over 4 hours and then repeated for 5 days. So that's pretty resource intensive. But having said that, they did show that at 90-day follow-up, there was a significant reduction in pain. So the same study tried to, do a much larger study, but then they found that there was no significant decrease in the pain scores. There was some improvement in the sensory subscales that they looked at. So given that it was the same center as the authors looked at the data from both, and then they figured that maybe one of the contributing factors that it did so well in the smaller pilot study was that they had recruited more early CRPS patients. So that might be something to, I don't know, consider in our, stratification of patients who might be an early CRPSer. Then there's an interesting case report that documented complete analgesic in a patient, a woman who had CRPS for over 10 years, actually already had a spinal cord stimulator in situ, and she became pregnant and underwent or developed preeclampsia, so received a magnesium infusion as is the standard of care. And as a result of that, during her entire labor and delivery, she had complete resolution of her CRPS pain. So as soon as the infusion was stopped, her pain returned. So it does go on to document later on that the patient sought out, repeat IV magnesium infusions, but again, was only able to replicate that relief during the actual infusion itself. But in somebody like that, I would wonder about the role or the value of a loading protocol. In terms of its use in infusions, when we look at, its use in chronic pain, most of the studies that have looked at this look at magnesium versus ketamine specifically, probably because of the NMDA action. And the bottom line is it does not outperform ketamine. It does result in significant pain relief, but it is more on the temporary side. It doesn't have some of the prolonged effects that, ketamine seems to have. In terms of blocks that we might do, there was a meta-analysis that was done recently. I think it was published in the last year on the use of magnesium in peripheral nerve blocks. Now, granted, this is in the perioperative setting, not in chronic pain patients, but it did show that blocks done with magnesium showed a prolonged effect. It took less time for the block to kick in. And with tap blocks specifically as a sub-analysis, there seemed to be less nausea and vomiting side effects as a result of the block. So it could be interesting to see whether or not that has any role in some of the peripheral nerve blocks we do. In terms of prescribing it, so IV magnesium, keep in mind that most of this, 90% is going to be excreted within 24 hours post-infusion. So it's not something that's going to stick around. Rapid infusion carries the most risk for toxicity, so something to keep in mind. But that typically, like when you look at some of the studies that have been done, like of up to 10 grams, like we wouldn't potentially be using it at that high level dose and in a fast infusion rate. So what we do, at least it seems to be the case in Ontario because of the way the billing works, is most centers seem to combine lidocaine and ketamine infusions together. And at least 2 centers that I know of, and ours, uses magnesium as a standard in all of their lidocaine infusions, typically 2 grams. I'm not sure if it actually, like based on the evidence we've just reviewed, if it actually really does anything to prolong the benefit or provide additional benefit, but it isn't competing with ketamine. So it is, I think, from that point of view, fine to use together. And if you think about, you know, what I think would be the main argument to use it in an infusion is that it actually probably increases the safety of the lidocaine infusion. When you think about the risks we're counseling patients in terms of the risk of seizure and stuff like that, given that this would potentially counteract any seizure-like activity, it's probably from that point of view alone justifiable in including it, with question mark benefit for pain as well. In terms of prescribing it as an oral supplement, so I mentioned before, my preference is magnesium glycinate because it is the best absorbed, has the least GI effects, and splitting the dose is usually the best way to approach it. You can take it safely together. However, you're more likely to have the laxative effects when you're doubling the dose. So it just depends on the patient preference. Magnesium citrate, that's the one that has most evidence in migraines. I take liberties and still prescribe glycinate. Then in terms of what's actually covered, gluconate, hydroxide, oxide, and Rougier are all covered by RAMQ. And in Ontario, we only have coverage for magnesium hydroxide and magnesium oxide. So I will still prescribe them, especially if a person's constipated. I consider it a double win, but if they already have loose stools, then I don't know if they'll tolerate either of these options. But it's a discussion with the patient, especially if they're, you know, looking to, you know, start with simple measures first. In terms of transdermal formulations, so yeah, this slide's for Steve. Steve's an internal medicine resident I trained under a few years ago who had an intense love for ketamine. So my intense love for magnesium just really went well, and we really had some interesting chats. He challenged me on the idea, you know, that transdermal magnesium was even adequately absorbed. So this is kind of what led to looking into that. So there are studies that show statistically significant changes in the serum and urine magnesium levels with transdermal application. However, I don't tend to use them because they tend to be very expensive, and I think the oral options give us bigger bang for our buck. There's a lot of marketing, though, that pushes the idea that there's better absorption. So if somebody wants to consider that, I usually suggest if you really want to try absorb it through your skin and you don't tolerate the gut side effects, you can do Epsom salts baths like once or twice a week with a hefty dose of Epsom salts. I usually suggest 2 cups in a really hot bath as a cost-effective version. And when you look at some of these centers that have popped up, we have one in Thunder Bay, a float center. That's supposed to be like sort of like a sensory deprivation tank that's high in like it's very buoyant because to give you that sense of weightlessness. But how they achieve that is actually with Epsom salts. So they just load that that tank with Epsom salts, and I wonder if a lot of the therapeutic benefit from that comes from the surge that people get in their magnesium levels by doing that. I mean, there are people that go on a regular basis for these floats and swear by them. So I mentioned a loading protocol, and this is something that I stole from CHIO. I thought it was interesting, and I have used it on a couple of occasions when I really feel like a patient is profoundly low and they would benefit from a more rapid approach to restoring their tissue stores. And it basically gives the patients guidance on how much magnesium to take and increasing the frequency. And the goal is to increase your dosage until you get loose stools. And by that point, you reduce the number of your capsules by 25%, rounded up, and you carry on at the lower dose again until you experience loose stools, again reduced by 25% until you get to probably around two a day for maintenance. Now, it's interesting because I kind of wondered about this when I first saw this. They actually specifically recommend Pure Lab vitamins. And one of the challenges with supplements in general is that it's not a regulated industry in Canada. So the quality can vary quite widely between companies, and it may not even include what it says it includes. So there was a study that, or not a study, a marketplace thing that looked at that. And so that's really frustrating. But when I looked into this, this recommendation that the hospital made, which I found very surprising, it's probably because this company has won industry awards for quality. They're also located out of Ottawa, where CHEO is, and they do make a reasonably priced product. So I often, if patients ask, will specifically suggest that, not because I'm affiliated or have any financial incentive in doing so, but I think that's the environment we live in. It is a problem with the lack of regulation in Canada on that. So to sort of close off, let's say that all of this is fluff and it doesn't really do anything, and they do better studies and it still doesn't show anything. Well, you know, we talk about a lot in pain medicine about this idea of the placebo effect. And, you know, if it was only possible to prescribe something. Now, here you have a molecule that theoretically is involved in multiple roles in the body, that has, you know, a very logical physiological role that may or may not do something for pain. The verdict, you know, is still out from a research point of view. But you have something that's, generally speaking, very safe. It's not really invasive. And if I had to think of a placebo molecule that might serve me and might not, I can't think of a better one. Because you can reasonably suggest to patients, look, this can be good for muscle relaxation, can be good for, you know, reducing issues with nerve pain, potentially, reducing problems with sleep. Some people find it very helpful for sleep, nocturnal leg cramps, that kind of thing. And whenever I have somebody, especially sitting in front of me as a physician, where they say to me at the end of the assessment, well, I don't want medications, or I don't want injections. Well, that sort of kind of really, you know, limits what I have to suggest for the patient. I mean, certainly I'll maximize all of the options they have at our chronic pain program, but it sort of ties my hand in sort of in terms of the tools that I can use. So this is where I go with supplements, and I try to build up a therapeutic rapport. And then if it doesn't work, and maybe by the time they come back, they're more willing to consider other treatments that might work better over time. So I'm just going to plant that seed that I think it's reasonable from that perspective as well. So these are my references. You know, it's sort of like my collection that I've accumulated over time, for anybody who wants to do a deep dive. And that is pretty much it. So I hope people are still awake, and I'm going to stop sharing. I'm happy to take any questions.